The decisive topics in axillary management currently are mostly defined by the extent of axillary surgery and by the extent of lymph node irradiation. So there is an overlap. Axillary surgery mainly involves the lower part of the axilla, what in radiation oncology we call level 1, and it used to be including level 2 and even interpectoral levels, but nowadays we see that in general axillary lymph node dissection only removes level 1 nodes. Most patients, fortunately, nowadays have more limited axillary interventions, the sentinel lymph node biopsy for those who are clinically node negative. Patients who initially were clinically node positive will often be offered, depending on the biology of the tumor of course, primary systemic therapy to obtain volume reduction of the tumor load. And if a sufficient volume reduction is obtained, we can proceed to less extensive axillary surgery to replace axillary lymph node dissection by only sentinel lymph node biopsy followed by radiation therapy. The main remaining discussion is what if we do a sentinel lymph node biopsy, we didn't expect, but there are tumoral cells within the lymph nodes. Do we need to proceed to more surgery, or can we replace a surgery by radiation therapy? What's often forgotten by the younger colleagues is that 40 years ago, when I started my career, about half of the patients had clinically significant complaints of lymphedema. Nowadays we see that much less. Thanks to earlier diagnosis, less extensive axillary surgery, also better techniques, less aggressive axillary surgery, and better radiation therapy. So nowadays it's not a very small minority, but it's overall a minority of the patients who still have lymphedema. So how can we further reduce that? How can we reduce the burden of the treatment, and in this occasion it's about axillary treatment for patients with breast cancer who have axillary lymph node involvement?